Good afternoon, everyone. We're just going to give it a few minutes just to let everyone get on, and then we'll make a start. Okay, I think there's maybe a few people who are having some difficulties getting logged on, so we'll just give them a wee minute. Okay, so we're just going to make a start, and I just want to welcome everybody to what is our first RCSLT Hub webinar. And I think we are in equal measure excited and nervous to be running this today. So hopefully everything will work, and we really will be able to celebrate the impact SLTs are having in people's lives. So some of you might be wondering, well, who even is or who are the RCSLT Hub? And I'm just going to give you a very quick introduction overview as to who we are. So RCSLT Hub is a group of RCSLT members from a very wide range of backgrounds. So there are representatives from the trusts, representatives from UU. So we have student reps on our group, independent sector is represented, our retired members are represented, and the heads of service are represented. So there's a wide geographical spread across the region and also across specialisms. So right from early years and early intervention through to adult services. So this is a proactive group of RCSLT members and has been recognised right across nationally as being one of the most active hubs. So really, our aim is to work for the benefit of RCSLT members in Northern Ireland to ensure that your voices are heard and your voices are represented as well. So it's that group that you can see in front of you. It's that group that have come together today to put this webinar on. And I just want to thank each and every one of them for their help and assistance. And it would be remiss of me not to thank Jenny, I will be thanking you as well, to thank Janet McGuckin, who has been working in the background just to pull this all together and has really taken this on. And thank you, Janet, for everything that you have done. So we have a packed programme this morning or this afternoon, and really we are going to celebrate the impact that SLTs have on people's lives. Now, we won't be having a question and answer session just due to time, but if you do have any questions for any of the presenters, there will be a slide at the end of each presentation which will have the contact details for the presenters. So please do contact them. Do make those links and those networks and connections as a result of today. So we are using the webinar version of Zoom today, so your microphones and your videos will be disabled, but please do use the chat function to engage throughout. And also at the end of the webinar, we'll be launching a poll, and we would ask you to respond and give us your feedback so we can reflect on this webinar today and we can think of the way forward and our next steps. We'll also be using Twitter, and the hashtag is celebrating SLT, so please do use that. and the webinar will be recorded. So the link will be sent in the next RCSLT link that goes out to members. So we're just going to get going, and it's my pleasure to introduce our first speaker, and that is Jenny Keane, who many of you will know. And Jenny is the outgoing Chief Allied Health Professional Officer for Northern Ireland. And we're just delighted, Jenny, that you have had time to join us today, and we're really looking forward to hearing you. So I'm going to pass over to you. Thanks, Jenny.
Thank you, Alison, and thank you, RCSLT Northern Ireland, for the invite. I was absolutely delighted to get the invite, and even more delighted to be able to have had the time to spend some time with you today, not least because of the support both the professional body and all of you as clinicians, academics, have given to me over the last couple of years. You really, some of my greatest friends, and definitely some of my go-to people are those of you that are on the call. And I now feel like I can even use the word speeches, which I hadn't heard of up until I'd taken up this post. So what I'm going to do, just in a short couple of minutes, everybody, is briefly give you an overview of how SLT has shaped how I do my job now, and the role of what you do in terms of influencing policy, and my thoughts around that. So in essence, my role here in the department is to provide professional advice to the Minister, to the Northern Ireland Executive, and to all of the senior policy leads on how the allied health professions can improve the health and well-being of the population of Northern Ireland. I'm just seeing a wee note. Is there real issues with my sound? Okay.
It seems okay, Jenny.
Okay. So it's to really be able to provide that advice around how you as a profession can impact and be seen visibly in policy to be able to improve the health and well-being of all of the population across Northern Ireland. So it's quite a high strategic, broad level objective. And the thing I need to probably break down is, well, how do I go about doing that? So how do I do that, and where is my network and my input from you as a profession in how I do that on a day-to-day basis? Well, the way I do it is, first of all, it's to be able to understand what you do and what you do uniquely as a profession. So really being able to advocate and to articulate what your so what factor is. So your real, that real how, the so what, the, that real essence of what it is you do that's unique. And really importantly, what the impact is if you don't have that so what. So that so what if it's not there is really important in terms of me being able to articulate why you need to see what you do in core within programme for government and within policy. So that's the first thing that I have to do, is be able to understand and advocate the uniqueness of what you do. The second piece for me is then being able to plan and build the expertise within the workforce, so that that capacity, the capability and the leadership is there within the profession to be able to realise that unique input and to take it forward. So then, I've described, I need to know the so what, and we need to have the people to do it. As a profession, speech and language therapy have been an absolute joy for me. Not simply, but for a main reason is you've got a really strong so what factor. You've articulated it really well, and your impact is really, really well evidenced. I'm able to take, high level, well evidenced research in terms of early years, mental health, rehab, rehabilitation and recovery. And I'm picking on those three areas because they're the three things which I have utilised evidence and expertise that's been there from speech and language therapy over the last short number of months even, but certainly over the last 18 months. So that evidence is there at a national and at a global level. But I've also got really good, strong local examples of the impact that you have been making in early years and in mental health and in rehab and recovery. And from a political context, people, the decision makers can relate to it because it's local, but it's also linked to that national and global evidence. So you really, as a profession, punch above your weight in the context of being able to articulate and describe your impact. So for me, the uniqueness of what you do is being able to link your day-to-day practice to that very high level strategic outcomes. And when I think now, today, and the key big problems of our generation and the key big strategic drivers that are actually coming out post-COVID, if we can even say post-COVID. And for me, when I hear language like levelling up, when I hear the conversations around addressing health inequality, building back better, there's a golden thread that links through all of that. And particularly when I hear the conversations around levelling up. And for me, that is social justice. As a profession, what I see is that with all of your practice, regardless of what specialty you're in, you have a desire to bring about social justice for the populations that you are working with in addressing health inequalities. So for me, ensuring that the essence and impact of speech and language is in all of the key policy drivers and decisions will bring about social justice for our population and within our communities. And I think that's something which is something you're particularly good at as a profession, particularly good at. I've been very fortunate, as I've said, in my time here, in having a professional group, within your professional body, but also right across the workforce, in being very generous with your examples and with how you work out loud. And I think that's, it's probably quite ironic when you think of speech and language therapists, but it's really important that you continue to work out loud, that you showcase your work, and webinars like today are very, very important. I had been writing down a few notes, and towards the end of my couple of minutes, I had started a paragraph that said, well, my challenge to you would be, and I thought, well, actually, no, that's not correct. It's not my challenge to you. It's my hope, and it would be my aspiration that you continue, as I say, to punch above your weight, because you're a relatively small profession, but you are able, because of your size and because you've got such a clearly defined unique selling points, unique impact pieces, that for your size, you are able to stay connected between the really high level policy impact piece to the on the frontline case study interaction with patients. So my aspiration is that you continue to do that. I think it's really important that as a profession, you celebrate your uniqueness and your positive, what you do and what you do well. What you do, I don't think you need to dress up. I think it's enough. What you do for your service users and what is core to speech and language therapy is enough. I think you need to celebrate what you are, you don't need to look at what else you can become. You are enough in what you do. And I think my aspiration is that you continue to make those connections between what you do and what the big picture is and what those big picture outcomes is. And the last words that I have down here is 3 words, and that is work out loud. Continue to work out loud, because what you do is, like I said, it's enough, but it's really valuable to ensuring that we have a social and just society. So that's me, folks. I think I hope I've kept to time. Alison, I hope that's, and Ruth, I hope that's enough. I'm going to listen on to the rest of the webinar. I may need to leave a little bit early, but I do hope to be able to listen to some of the speakers.
Thank you so much for that, Jenny. Oh my goodness, I absolutely love that too. That phrase of work out loud is something that I think a lot of us will carry with us. Can I just say as well a huge thank you on behalf of RCSLT NI for your support over these last few years. And that comes from Vivian, from Ciara, from myself in these last few months, and from our members here, because we have truly valued your honesty and your passion for raising the bar when it comes to us AHPs. And we know we are a small profession and amongst some of the bigger giants there. We are absolutely gutted to see you go. For those of you on the webinar that don't know, Jenny is leaving us for bigger and better things. And I just want to say that Northern Ireland's loss is truly England's gain. We are excited to work with Suzanne Martin, who's incoming. But Jenny, please don't be a stranger. Thank you for everything that you've done for us, and good luck in the new role. We know you will absolutely ace it. Okay, so moving on, I'm going to share briefly about me very, very quickly, and then talk for a few minutes about speech and language therapy and emotional well-being. So very briefly then, these are some of the things that have been or currently are a big part of my life. And actually now looking at this, I feel quite bad because I don't have a picture of my husband in there. So any of you that know him, please do not tell him. As a lot of you will know though, I come from an adult speech and language therapy background. I did have about 5 months in paediatrics about 16 years ago, but since then it's been adults, acute community settings, then on to specialise in dementia and more recently mental health. And during my role in dementia, I worked with RCSLT NI, and it was Alison McCullough at the time and Janet, to launch the communication booklet and an event in the Long Gallery. And fast forward then another 6 years to work with Ciara and Vivian on the mental health strategy and to speak to the health minister. I truly believe it was these wonderful opportunities that even gave me the notion of considering to apply for this job. And what I'm loving in the job is the variety of things that yesterday I got to spend the morning learning about the Help Kids Talk programme and being able to immerse myself back into so many clinical areas that I had left behind many years ago. So this is an accurate reflection then of my reaction to the job offer. When Derek phoned me, I actually said, really? And a few days later, he asked me if I'd gotten over my shock. I still don't know if I'm over the shock, but here we are. And 5 months later, I still feel quite new, but I am loving the challenge. And as I said, the variety it brings. I love working with Vivian and Janet, and I'm excited to help them support you in any way that we can over the coming years. So just a few minutes left to touch on emotional well-being as a speech and language therapist. It's a huge area, and this is literally a very light touch. But before I do, can I ask you all right now to just close your eyes and begin to notice your breath. Now, take a deep breath in through your nose, and then allow a slow exhale through your mouth. And now do that again, in through the nose, and release, maybe even in a sigh. And then open your eyes. It's amazing just what that conscious breathing for a few seconds allows us to do, that we can reset and be ready. I want to begin by being really honest with you and saying that mental health is something that I will probably always struggle with. I've had time off. Those of you that know me will know I had time off work in 2017 following some panic attacks, and it was in relation to a particular patient that I had that was tricky. with dysphagia. But I know that I'm not alone, that many of us struggle with certain parts of our jobs, be it inputting into statements, tribunals, court cases, or with dysphagia. So you're not alone. I don't want you to ever think that you need to keep your thoughts or anxieties to yourself, but really consider sharing them with a trusted source. And I'm glad that I did. What I would encourage managers and team leaders that are here is to really promote and encourage peer support. Encourage a culture of compassion, sharing, openness, and prioritize it in your team. I have a real passion for this because in my darkest times, I honestly thought that I could never return to clinical practice as a speech and language therapist. I thought I was done in 2017. But I'm so glad that I did. I persevered. I got the support that I needed from my GP, from counselling, through yoga, and lots of other ways. I also had the support of my SLT manager and peers. So this is a real priority for me in this role. I want us to look at how we can support and build resilience and well-being as a professional body. So this is not the last you're going to hear with me on this topic. Looking then at some tips, none of this is rocket science, okay? But sometimes when we get overwhelmed, and I know that I do, it's easy to let the little things slide. When you've waiting lists that are creeping up, we can push supervision. And I would really, really stress the importance of regular supervision and peer supervision as well, because let's face it, there are certain silly questions maybe, but they're never silly, that you don't want to ask your manager, or they might think, why on earth did I hire that person? So peer support is so valuable. So please, 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 if you don't already have it, encourage your staff to start using peer supervision as well. I feel totally hypocritical looking at that first tip about boundaries. I am the worst. Anybody that knows me will know that I'm the one sitting there trying to write notes at 6:30 at night. I just want to be like those OTs that can come in at 8 and leave at 4. So I'm a work in progress. And like Faith Hill says in her song, just breathe. Sometimes we don't even take enough time to consciously stop and breathe. And you saw, hopefully, just a few moments ago, how beneficial it can be to just take a few deep breaths. It wouldn't be right of me to not mention that RCSLT also have some good tips on there on resilience and self-care. So please do check that out if this is something that you're struggling with at the moment. And look, thank you so much for listening. I'm always happy to chat about this. So if you have any queries or questions, please do come and let's chat about it. And as I say, this is not the last you'll be hearing about well-being for us SLTs. So now I'm going to hand over to the lovely Marion, who is going to tell us all about her Tuck Shop project. So over to you, Marion.
Thank you, Ruth. Good afternoon, everyone. It's just a real privilege to be here today. So thank you to the Royal College NI for inviting me to speak today, and just to be on a panel with so many fabulous colleagues. As I say, it is a privilege. So a wee bit of background just to this project. I was appointed as lead speech and language therapist for healthcare in prison in June 2019. And I was already aware of the high incidence of learning disability, learning difficulties and literacy difficulties in the prison population. So it was no surprise that during screening and assessments, accessing the Tuck list was coming up again and again. So I started to devise some easy read versions with pictures and enlarged codes for individuals. And this was kind of just based on their preferences. I would go through it with them. I then started to get more requests for easy read versions from other students, which was great, and also from other staff members, which was also great. So I decided it might be worth doing the whole list and making this accessible for anyone who wanted it or needed it, really. So why make the Tuck list easy read? Well, in terms of inclusive communication, I mean, obviously this is an overarching approach, which is relevant to everyone and not just those with identified communication needs. So that was important. And also the 5 good communication standards were very much going to be at the heart of my work. And in particular, standards 2 and 5, where services demonstrate how they support individuals with communication needs to be involved with decisions about their care and their services, and also how individuals are supported to understand and express their needs in relation to their health and well-being. And as you can see, then the next few points are very much about health and well-being, and in the hope that I would, positively influence behaviour as well. And there was an opportunity here for co-production. So being able to involve the students themselves, the NIP staff, who are the prison staff, and health staff. So involve them from the outset, getting their views, piloting it with the students and the TUC staff, and getting their ideas, even around the layout and how it would look. So having them involved in the rollout as well, and updating and amending the TUC list as necessary. So why make the TUC list easy read continued? So as you will see there, that was why we needed to make it easy read. Things are not, there's no lines. It's very small text. The codes are very small. So it was very easy for people to make mistakes. It is alphabetical, but as you can see, things aren't in categories. So at the very beginning, we have bran flakes up at the top and Weetabix down at the bottom, and that's certainly not how it is in the supermarkets that we go to. So there was lots of reasons to make it easy read. So I devised a simple survey to get a sense of how difficult it was for the people living in Hydebank to navigate this. And with the help of one of the occupational therapists, I collated this information in November 2019. So we actually went around the site ourselves and supported people to complete the survey, being mindful obviously of literacy difficulties even in getting to complete the survey too. And these were the results. So as you can see there, if you tally it up, at least 50% of those surveyed found the TUC list either difficult right down to impossible to navigate. And this was no surprise really, I suppose, given what we know from national statistics around literacy levels in the prison population. But I suppose it was good to have local data as well, and really see that this was something that needed to be done. And this was what some people had to say whenever we went around the site itself. So as you can see there, people really did need the TUC list addressed, and we did need to make it easy read. And some of the things that stood out for me there were just things like people ordering the same stuff because they couldn't be bothered. So that idea of not having choice, which is really important. There was another lad said to me about not realising that he told me he had no issues reading the TUC list. However, he never knew that there was pickled onion space raiders on, because the beef space raiders came first and there was all other kinds of crisps in between because it was alphabetical, but he just hadn't actually gone ahead and read the rest of the list. And they seem like simple things, but when you have very little control over a lot of other things in your life, when you're in prison, the TUC list becomes very important, having something to look forward to. And as I said earlier in one of the slides, having that sense of agency, independence, and being able to do something for yourself. So this is now what it looked like. So this is a sample of how it looks like. The OT and I worked to compile this. It was very time consuming. And then we enlisted the support of the health development worker who helped us to cross-reference the list and look for any mistakes and things like that. We also worked very closely with the staff in the TUC shop. Now, the staff in the TUC shop is made up of prison staff and as well as people who live in Hydebank. In the new year then, the OT unfortunately had left, but following a speech, language and communication awareness raising training for staff, our dietitian came on board. So that was when we decided to add dietary information as well. COVID then hit, as we all know, and between staff shortages and reduced movement on site, being able to move around the landings and things like that, we then didn't get to actually launch the pilot until October 2020. So on International Food Day, for those of you that maybe aren't aware, or if you're foodies like me, maybe you are aware, there's an International Food Day. The students were provided with a healthy snack pack, and the team, which was myself, the dietitian, and our health development worker, visited all the landings to discuss healthy eating and highlight the introduction of the Easy Read TUC list pilot. It was piloted on one male landing and one female landing, and then also on the landing where most new male committals come in. Prison then came on board to get it printed and bound, and then a copy was put out onto all landings earlier this year. So in terms of outcomes, well, it's actually been quite difficult to measure, unfortunately, because of some of the challenges listed on the screen here. So copies did go missing. Staff maybe don't always make it available. There's a high turnover of people who are on remand. They come in and out, and as well as staff shortages and sickness as well. And there was a bit of a stigma maybe to it, that it was only for people who had some kind of difficulty. But generally, there has been increased awareness of speech, language and communication needs. The fact that other prison staff now are asking me for advice on making other documents easy read is a real win. And, recognizing when people might need it. So I think, we need to build on that. And really in terms of training, we need to just continue with the training to help raise awareness even further. Going forward then, I suppose some of the things we want to do is ensure there are hard copies available on each landing and make sure that they're being used. We might want to match the pictures to the actual stock. To date, we've only used pictures off the internet. Trying to have like a tuck mate, maybe staff and students could come on board to support other people. We also thought about a potential for linking to an ICT qualification. So getting Belfast Met and Education on board, have a student responsible for updating the list, monitoring usage and things like that. There's also a regional project with NIPS who are looking at having the prison tuck list online. So there's a potential to link in with that. We probably want to revisit just the usage of it and maybe take feedback again or do another rating scale and see if there are any suggestions for improvements. And we wanted maybe to try also to map changes to ordering, and the dietitian as well was very keen for us to look at maybe, are people ordering healthier foods? Are people thinking about, or even just changing it from week to week, so that issue of choice is being addressed. And I would want to think about, on top of our speech, language and communication awareness raising training, that we can then provide more training maybe around inclusive communication, the 5 good communication standards, or making things easy read. So that's the Tuck List project. Thank you for listening. And if anybody has any questions, there's my details on the screen.
Thank you so much, Marion. Such an interesting project. But we're going to keep going with our webinar and move on now to the lovely Ruth Miller and Marialva Alves from Southern Trust, who are talking about their campaign of speaking Teton at home. And I really hope that I've said that correctly. But over to you.
Right, thank you very much. Hi, everyone. My name is Marialva Alves. I am a bilingual family support worker from the Ghana Island Sure Start. Myself and Sure Start Speech and Language Therapy, Ruth Miller, are very grateful for the opportunity to share our Speak Teton at Home initiative with you today. Speaking Teton at Home is a campaign that was devised in response to our work with families from East Timor. From those of you who don't know, East Timor is an island in Southeast Asia. Previously a Portuguese colony, it was embroiled in a long conflict before achieving its independence from Indonesia. It's currently considered to be a developing country. Many families from East Timor made the move to Northern Ireland to seek employment. Ghana has the highest number of East Timorese families in Northern Ireland. East Timor is a very multilingual country. There are 3 official languages, Teton, Portuguese, and Indonesia, in addition to 32 local dialects.
As Sure Start practitioners, we began to hear feedback from the Sure Start developmental program for 2 to 3-year-olds and also from local nursery schools that children born to parents from East Timor were presenting in preschool settings with little or no home language. Unlike their other bilingual peers, they were then going on to become monolingual speakers of English. This has implications in that these children are at risk of losing their home language within a generation. This concerned us greatly as we are all aware of the benefits of bilingualism for children's social, emotional, cognitive, and linguistic development, as well as their identity within their family and community. We decided that we would actively set out to promote the use of Teton as the first language for children born to families from East Timor. Our Sure Start project manager, bilingual family support worker, Sure Start speech and language therapist, and Sure Start artist in residence launched the Speak Tetum at Home campaign. This consisted of awareness raising training for both our Sure Start and wider professional colleagues, with the aim of enabling them to also support families from East Timor to use their home languages and not abandon them in favour of English. A baseline questionnaire was sent out to all of our registered families from East Timor to ascertain their family experience, attitude towards, and expectations of using their home languages, as well as the use of English. In the absence of Tetum resources, we created an advice leaflet about the benefits of bilingualism. This was sent out to all of our East Timorese parents, our health visiting colleagues, and GP surgeries in the area. We also created the Speak Tetum group, which children and parents could attend in Sure Start to hear the use of Tetum during play. In addition, a video was produced which was shared on Dungannon and Cool Island's Sure Start social media page and shared with other Sure Start projects in our area. This video is also to be played to East Timorese parents while they are waiting on their centre-based antenatal appointment with our Sure Start midwife. We will now give you a short taster clip of the video, which can be found on YouTube.
Janet, we haven't got any volume.
Ia ina mi isi, sira belerona ona itanilia. Idane hatudu katak antes de itani bebê morishmai, bebê sira rona saída makita kulia,
Can you hear
sira
me now?
mos reconhece itanilia.
Yeah. Lost the volume again.
Halo la baik sira confusa, no halo sira kulia tarde. Mito cerne la loja. Bebê o la baik sira cérebro, ia fio barak bebê makbela ajuda la baik sira a tua capta liang o oi. Se la barik sira rona liang o oi, se la confusa sira, mas bem se ajuda sira a tu aprende, no for vantagem ba sira a tu aprende liang selo. Ajuda la barik sira ser bilingual. Wangira la barik sira kuliah liang rua, ia benefício barak teves ba sira. Aqui ita niwang holiam barak, bela ajuda sira desenvolver seu cérebro, ajuda ser minha autoconfiança, bem-estar, e habilidade.
You will see from the artwork in our video an advice leaflet that we use the national symbol of crocodile, the tie pattern from our traditional cloth, and flag from East Timor throughout. We wanted family to feel proud of their East Timorese heritage and ability as multilingual speaker, and to foster this sense of pride with their developing children. Some of other Tetum speaking only groups available for East Timorese families and their children are listed here, and there's a good uptake into these groups. We wanted parents to understand that in SureStart itself, we also embrace and encourage use of their home languages. SureStart staff also grade East Timorese families using Tatum, which they really like.
Analysis of the responses from our questionnaire did indeed confirm that before the Speak Tatum at Home campaign, families from East Timor were found to place more value on their child learning English than Tatum. Interestingly, a significant number of parents did not think that it was possible for their child to learn Tatum and English simultaneously. At this moment, the Speak Tatum at Home campaign is ongoing. It has highlighted the need for the availability of more resources in Tatum and the need for more Tatum speaking health and education staff.
We would like to thank you for taking time to hear about our campaign today, and we are happy to be contacted if anyone would like further information. So thank you very much.
Thank you.
Thank you so much, Ruth and Marielva. That was so fascinating. Loved hearing all about it. So, excuse me, moving on now to Joanne Matthews, who's going to tell us all about her project in implementing 5 good communication standards. So over to you, Joanne.
Thanks, Ruth. Thanks, Ruth, for having us today and for having me, and also for making me realise that my shoulders were right up around my ears when we did the breathing exercises, just having to relax a little bit. So I'm just going to tell you a little bit about a project that we had been involved in. So as a speech and language therapist, the importance of inclusive communication for everyone accessing healthcare is paramount, but it can prove challenging, especially for those with a learning disability. High-profile reviews such as Winterbourne and Muckamore Abbey suggested that improved communication support may have resulted in earlier detection of abuse. And in response, the RCSLT back a few years, in conjunction with the National Learning Disabilities Senate, had developed the 5 good communication standards as a means of supporting the communication needs of those with a learning disability. With this background, along with trends within the ALD service in the South Eastern Trust, we found that referrals were mainly for dysphagia. There was a poor understanding of the communication deficits, which led to a reduced number of communication referrals. Communication was not seen as a priority. Dysphagia had become the priority, and there was a lack of awareness of the 5 good communication standards in both day centres and supported living facilities. This prompted the ALD staff team, which was Geraldine Napier, our clinical lead, and our SLTA, Elena Vance and myself, working along with day centre staff to implement a project using the 5 good communication standards as our benchmark. And from the outset of that project, we had to demonstrate a very supportive and empathetic and a non-confrontational leadership style with the day centre staff. The aims of the project were to raise awareness of and implement the 5 good communication standards and to train and equip staff in communication. It was very much a partnership between the SLT staff and day centre staff in 2 statutory day centres across the South Eastern Trust. One of them was in Downpatrick and the other was in the Lisburn sector. Initially, the project had been to include 3 day centres, but due to our own staffing issues and changes, it wasn't possible to complete the work in the North Down and Ards sector. So once we had identified who would be taking part in the project, our initial measures included completion of the baseline audit, the RCSLT audit tool. This audit tool was devised by the Adult Learning Disability National Leads Network, and it was adapted for specific use within Northern Ireland by RALD. And the audit tool is a traffic light system, and it identifies if a service is fully meeting the standards, partially working towards meeting standards, or they haven't even started meeting the standards. And we completed this pre and post intervention. We also completed confidence and satisfaction questionnaires with staff working in the project rooms before intervention and then again at the end. During the project, we did communication assessments and communication profiles, completed providing individualised advice for supporting individual service users. We had individual and group therapy through provision of narrative stories and music calm groups. We looked at the communication environment and we assessed it and tried to enhance it to support understanding and expression and to create opportunities for communication. So we put in visuals for Makaton signs, weather charts, choice boards, room schedules, pane charts, menus. We looked at all of that. And then we had communication training to equip staff with the skills needed to identify communication difficulties and then to support service users' communication, and we delivered that to the day centre staff. As a byproduct of the whole thing, the South Eastern Trust and the Northern Trust ALD clinical leads trained RQIA staff in the 5 good communication standards and what good communication looks like. So how did we do? This is a little summary of some of the findings. So red is not meeting the standard, orange was partially meeting the standard, and green was fully meeting the standard. So you can see there was considerable improvement across standards evident by the reduction in the red and the increase in green post-intervention. And it wasn't equal across the 2 centres. Both centres required some ongoing work, and we actually felt that those centres that had more consistent staff did better. There was an overall increase in communication referrals of 80% compared to the previous year. And that highlighted that there was an increased awareness of the communication needs of the learning disability population. At the outset of the project, it was anticipated that all the staff in the individual target rooms would be trained in the 5 good communication standards and get some communication training. And it was initially proposed that we would do this by training the staff on the ground with like short pop-up training sessions. In practice, this was unachievable due to staff shortages, inability to maintain key staff in the room. There was a high percentage of bank staff and there was difficulty freeing up staff. And so to counteract that, we had to rethink, and training was made available on the day of the training centre week. And that resulted in like all of the staff being trained in Mount View and 42% of the overall staff in the other centre being trained in communication. Completion of the project has increased staff's awareness of the standards and the need to support service users with learning disabilities who present with communication difficulties. Pre and post intervention questionnaires highlighted that staff feel more confident and better equipped to identify and support those with communication difficulties. And then using TOMS via the root system, we did pre and post intervention. We demonstrated that there was a 53% increase in staff and service user well-being. And the day centre staff then felt more empowered and confident to take on intervention groups after we had the project had finished. Staff evaluation of training indicated that the training that they had received, they were very satisfied, and they rated it 4.9, which was very good. The key challenges, staff shortages proved to be a big challenge. So the core staff in one room were regularly pulled out of the room to go into other rooms to help cover staffing. So then we couldn't identify key staff in the room. There was a real high percentage of bank staff and agency staff with varying degrees of knowledge and experience in supporting communication needs of service users. Availability of the daycare workers to help roll out the training wasn't consistent. And this was a pilot, and our plan had been that we would upscale and spread, but this hasn't been possible yet due to staff shortages and changes, lengthy waiting lists, and then obviously COVID. What became really apparent to us was that when there's consistent staff in a room to support service users, that the aims of the project were much more effectively implemented and staff satisfaction was higher. Inclusive communication training needs to be included in mandatory workforce development plans. And RQIA are now asking for evidence of the 5 good communication standards as part of their inspections work, which encourages the staff to really think about and implement the audit tool within their everyday work. Our future planning would be that we would upscale and spread the project to other ALD settings with the potential for a PPI project to develop a toolkit for the 5 good communication standards with learning disability staff. Thank you.
Gosh, thank you so much, Joanne. Isn't it amazing whenever the data actually speaks for itself, and when you can see that so clearly, because I think so often it's quite hard to prove what we do, even though we all know it's wonderful. So thank you so much. Okay, moving on then, we've got Alex McNeil and Erin Stewart who are going to talk about telehealth and the results of their audit. So over to you.
Okay, so our project evaluated the use of telehealth as a method of service delivery in response to the COVID-19 pandemic. Before the pandemic, within our service, our main method of service delivery was clinic-based appointments, but during the pandemic, this was substituted with telehealth appointments and no face-to-face appointments were offered. To measure the impact and benefits of this rapid move to virtual consultations, we evaluated the effectiveness of telehealth appointments to provide evidence of how the service had adapted, and also to understand whether this might be a sustainable model for services moving forward beyond the COVID-19 pandemic. We limited this study to those who attended for weekly support with speech sound development, and were working towards achieving their target sounds to phrase level.
So the first aim of our study was to evaluate the outcomes of telehealth within children's community SLT services, in line with key performance indicators that were outlined in the regional AHP virtual consultation guidance. So the key performance indicators we used were clinical outcomes and attendance. So data was collected during a case file review in March 2021. Information was collected regarding previous clinic-based or telehealth SLT input and the level of change achieved, and data from 170 cases was analysed. So attendance for telehealth appointments was compared with attendance for clinic-based appointments in the previous year, and a 5% improvement in attendance was noted with telehealth intervention.
So the level of change achieved ranged from children achieving auditory discrimination or their target sound at phoneme level to using their target sound at phrase level independently and starting to generalise the use of the sound. As you can see, comparison of the outcomes for telehealth and clinic-based intervention show that there is no significant difference between the level of change achieved across the two service delivery methods. Clinical outcomes for phonology intervention do not differ greatly depending on the method of service delivery. These findings support previous research by Wales et al., which suggested promising evidence to support the use of telehealth for delivering intervention to school-aged children.
So the second aim of our project was to outline the main barriers which may affect outcomes in SLT and compare the impact of these on clinic-based and telehealth interventions. During data collection, each file was reviewed to gain information regarding potential barriers which may affect outcomes in SLT, and where available, data was also collected for telehealth and clinic-based input. So this graph compares the barriers identified and the percentage of children who achieved significant change, which was achieving phrase level independently, despite the barrier for telehealth and clinic-based input. So as previously discussed, attendance levels were higher during telehealth input. Of the children identified as having attendance and commitment as a barrier to progress with therapy, 57.1% were able to make significant change in clinic-based therapy, compared to 18.75% in telehealth input. It is clear that there are children whose attendance pattern and commitment to intervention is suboptimal, and for these children, face-to-face seems to deliver better outcomes. So attention and listening difficulties are a significant barrier to change in both telehealth and clinic-based input. However, more children with attention and listening difficulties made significant change with clinic-based phonology therapy, and that was 66.7% compared to telehealth input, which was only 25%. So going forward, children with attention and listening difficulties, or those with low levels of attendance and commitment, may need to be prioritised for clinic-based intervention. 79% of children with a diagnosis impacting their ability to generalise skills from therapy were able to make significant changes with telehealth therapy. On further investigation, a similar percentage, 75% of these children also progressed with clinic-based intervention, suggesting that telehealth input does not have an impact on the success rate of phonology therapy for this group of children. These children can be considered for telehealth going forward. And lastly, children with stimulability of sounds as a potential barrier were not able to make significant progress with either clinic-based or telehealth intervention.
So to evaluate the views of parents and carers and clinicians, questionnaires were devised and disseminated to all staff and a random sample of parents and carers. Questionnaires were created using Microsoft Forms, and 17 parents and carers and 6 clinicians provided responses. We also evaluated the views of service users. The children who received both clinic-based and telehealth input were asked by clinicians which method of service delivery they preferred and the reason for their preference, and responses were collated for 5 children. So the advantages for parents included convenience, ongoing SLT input despite the pandemic, and their children achieving their speech sound targets. Disadvantages outlined by parents included technology difficulties and distractions in the home environments. 82% of parents felt that the support provided for telehealth intervention was sufficient, but 76% felt that they would choose clinic-based SLT input in the future if given an option. Although parents reported that they found telehealth intervention more convenient, they perceived that their children would prefer clinic-based input, which influenced their decision. Some parents reported that they would be satisfied with ongoing telehealth appointments if the technology could be improved. The main advantages outlined by clinicians included convenience for families, reduced risk of transmission of COVID-19, and increased parental involvement in the therapy process. The main disadvantages included technical difficulties, difficulties directing children with poor attention control, and increased screen time throughout the day. 80% of clinicians felt that they received sufficient support to deliver telehealth interventions. In all cases, clinician confidence using telehealth as a means of service delivery increased within a year of using technology to deliver intervention. 80% of clinicians felt that the use of telehealth had not had an impact on their overall well-being and felt that it reduced their worry around contracting COVID-19. Some clinicians reported missing social contact with service users and increased stress and frustration due to technical difficulties. All children that were asked reported that they would prefer clinic-based SLT input due to the perception that clinic-based input would be easier.
Overall, telehealth has been a viable method of service delivery for our service throughout the pandemic and should be considered further in the future. Ongoing use of telehealth means that the service will be prepared to offer telehealth appointments should it be required as the only method of service delivery in the future. However, it should be considered that there are also limitations to telehealth. Therefore, a hybrid approach to service delivery should be considered going forward, with families being offered either clinic-based or telehealth intervention as appropriate to the needs of the child and family. So that is us finished. Thank you so much for listening. Telehealth has been a whirlwind for all of us over the past year and a half, so we hope we find some of that encouraging for its use going forward. Thank you.
Thank you.
Thank you so much, Alex and Erin, for sharing with you. And thank you to everybody out there that has adapted their service delivery and what they're doing during the last almost 2 years of COVID. And speaking of COVID, that brings us to Amy Rooney from Northern Trust, who's going to talk about celebrating SLT and the Nightingale at White Abbey Hospital. So over to you, Amy.
Thank you very much, Ruth. So like Ruth has said, my name's Amy and I'm one of the Band 6 who currently works at the Nightingale Hospital in White Abbey. So today we're just going to talk through the Nightingale Hospital from when it was set up in November last year to what it is today, which is a general rehab and fracture facility. So if we go back to the very start, it was discussed with the Department of Health in September 2020, and we actually had our first patient admitted in November 2020. So that is a really good turnaround and very quick when we look at how long it can take up to set up the service. So it's a regional unit, and that means that we accept referrals from all of the trusts. We have a 14-day admission, so patients will have intensive rehab for 14 days. There are patients who stay a bit longer, but it is meant to be that they're there for 14 days only. So it's a nursing and AHP led, and it's the first time that this has happened within Northern Ireland. So we have an advanced practitioner, an advanced nurse practitioner, and a DP, and our advanced nurse practitioner has additional training so they can help with the medical side of things. We are very well funded for speech therapy, so we actually have a Band 7, a Band 6 and a Band 4 speech therapy assistant. We also have the 7-day service means that there is 7 days of rehab. So our OTs, our physios, our dietitians, and our speech therapists have rehab 7 days a week to patients. And because there is an increase in the amount of staff, whether that be speech therapists or OTs or physios or dietitians, it means that the patients can have more frequent sessions. So a lot of our patients do get seen on a daily basis, and sometimes they can be seen for swallow in the morning and then communication in the afternoon. So next, we're just going to look at a patient's journey. So this was one of the first patients we had. So this patient was admitted to the Belfast City Hospital in November 2020, and he was admitted with COVID. So as we can see, he had quite the journey. So he was intubated, a trachea was inserted, and then he wasn't decannulated until January 2021. So when he was initially seen by speech and language therapy, he had severe oropharyngeal dysphagia, and he was placed nil by mouth. Before coming into the hospital, he had no dysphagia and no communication difficulties. However, he did then present with dysphonia as well. So before the patient was transferred to White Abbey Nightingale, he was on recommendations, so he didn't come to us nil by mouth. And then when he was transferred to ourselves, he had very intensive input. So he was seen on 9 out of the 12 days that he was there. He was seen by a variety of speech therapists. So he was seen by band 5, 6, and 7, and that they did dysphagia and also communication. For his communication, he had mild dysphonia. So we just provided some vocal hygiene advice, breathing exercises, and there was an overall improvement in his volume and strength. For his swallow, we looked at some intensive reviews. He had frequent reviews, and by the end of his stay, his dysphagia had resolved, and his recommendations were level 7, easy to chew, and that was only because of his dentition. When he was discharged from us, he required no follow-up in terms of his communication or swallow, but he did have a follow-up within the Belfast City Hospital due to his time of being in ICU. So his follow-up in ICU, the patient had no concerns regarding their dysphonia, and they felt that their voice was within normal limits. His swallow, he had no swallowing issues, he had no trouble getting food down, and he was in the same recommendations just because of his dentition. He did say he had a general reduced appetite, however, he had no weight loss, and this was in April 2021, and there was an SLT present at that as well. So for the patients coming into the Nightingale, we do outcome measures, so we use TOMS. So during the setup, it was agreed that all professionals, all AHPs will use it. So the physios, OTs, and dietitians also use this. During COVID, we had quite a high percentage of patients being seen by speech therapy. So we actually saw 49% of the patients, which is a large amount. When we broke that down, we saw that 51% of the patients had treatment completed by the end of the 2 weeks. And that just shows by the increased staffing how much of a difference we can make, because we weren't referring them on to our community teams. So we only had 28% referred on to community, and 21% of the patients were then escalated onto acute care. Patients were seen for both swallow and communication within the Nightingale. So if we look at our previous patients' outcome measures, we can see his improvement overall. So he improved in all areas. So the blue is his outcome measures on admission, and then the green is on his discharge. His biggest impact was on his well-being, and that is something that we see a lot in the Nightingale, especially during COVID. The patient also completed a care opinion on discharge and made some really lovely comments. He said the staff were fantastic. He felt involved in his decision-making and his care, which is really nice to hear. He enjoyed that the staff updated family, and he noted that there was nothing to improve, which is brilliant. So now that we are a general rehab, I've just looked at how the improvements go across both areas. So this isn't to see the difference that it's made, it's just to show them both on the one slide. It's nice to see that there's still improvement in all areas. There's not as much an improvement in well-being, and that may be due to when patients came in with COVID, they were getting their independence back when they came to the Nightingale. So they just felt generally better in all areas. Whereas now there may not be as big as improvement in the well-being, but there's still improvement across all areas, which is very good. So moving forward, so the Nightingale is now a general rehab and fractures unit, so that changed quite recently. Our funding has actually now been extended to September 2022. So when I wrote it, when I'd written the PowerPoint, it was March, but it's just recently been extended to September 2022. We're still 14 days, we're still a 7-day service with intensive rehab. We still have our OTs, physios, dietitians, and ourselves, and we are still very well funded. So we've got a band 7, a band 6, and a speech and language therapy assistant. At the time of the PowerPoint, there was 24 patients, and I think we're around about the same now. We did have a change in how many patients need speech and language therapy, so there's not as many people who need it. However, we're still part of the team, and because we're there so frequently, we get referrals on the ward for communication and swallow, and we're part of the team, which is very beneficial. So thank you very much for listening. If there's any questions, you can just drop me an email.
Thank you so much, Amy. And such good news to have that funding from to September now, and not just to March. So moving on then, we've got David Curtin up now, who is going to talk to us about the impact of his prehab, and I should say award-winning project. So over to you, David.
Thank you, Ruth. So I'm going to talk to you all today about our head and neck radiotherapy Prehabilitation Initiative, which was a multidisciplinary team partnership here at the Northwest Cancer Centre in Knocknagalvin Hospital. So we're a team of 4 professionals across, we've got 3 allied health professionals and 1 clinical nurse specialist. And firstly, just to explain to you what prehabilitation is, the concept is about meeting patients before their cancer treatment starts. Macmillan published guidance on prehab back in 2019, and they describe prehab as enabling people to prepare for their cancer treatment by promoting healthy behaviours and needs-based prescribing. So by working in partnership with our colleagues and patients, we managed to co-design a project. So we consulted firstly patients who did not receive prehab, 21 patients in total. They described their experience of starting treatment or before starting treatment as largely a negative one. Generally, the consensus was patients felt scared. They didn't feel prepared for their radiotherapy treatment. They had no idea why they needed to meet a speech and language therapist or a dietitian, for example. Some were having swallowing problems already. They would have liked help, but they didn't know where to start. So what we did with this patient group is they helped us to co-design a project where we, if it's going to the next slide, so our collective aim was that we wanted to engage patients before treatment. We wanted to improve personal empowerment with an overall improved experience. We had ground rules as a team because we were 4 different professions and patients. Our shared vision was that we wanted to be responsive to patient needs, and we used quality improvement methodology to help guide our project. So the key pillars of prehabilitation talks about developing a personalized prehabilitation care plan for a patient. Macmillan really advocates that prehab allows a patient to take ownership of their own cancer story. And in doing so, that improves personal control, reduces anxiety and vulnerability. Talks about putting in place structured interventions to promote physical and psychological resilience and behavior change before treatment, personal empowerment to enhance quality of life, and to effectively use resources. We were innovative in listening to our patient needs, and we designed a bespoke side effects to expect leaflet, which outlined week by week the side effects such as dysphagia and dysphonia that patients could expect over the course of their radiotherapy. Equally, we designed an animated radiotherapy video, which simulated the radiotherapy experience, the sights and sounds of the machine, which we showed patients before treatment to desensitize them to the process. So our first patient to receive prehab was Kathy. She was a teacher with tongue cancer. She came to meet the team 1 week before she started her radiotherapy. She firstly met Malcolm, our radiographer. He explained his role and showed her the animated video. She then met myself and Kira. I'm the speech therapist, she's the dietitian, and then finally Angela, the clinical nurse specialist. We got to learn a bit more about Kathy at this prehab session. It allowed us to screen for any existing deficits and onward refer where appropriate. So here's the example of Kathy's personalized prehabilitation care plan. So there's 3 tiers of intervention advocated for prehab. First being universal, that's what all patients get. So she received the side effects leaflet that we designed. We advised her to self-monitor for any worsening or unusual symptoms. And our emphasis was on reporting issues early, don't ignore them. Targeted exercises was getting her started before treatment with mouth and swallowing exercises. And then a very specialist intervention just unique to Kathy was that she was already losing weight. I assessed her swallowing, she was at risk of aspiration, and then myself and the dietitian put in place a safe swallowing and optimal nutrition and hydration regime. She explained to Malcolm that she was very anxious around the radiotherapy machine. Therefore, Malcolm and Angela, then our specialist, arranged a visit for her to attend the radiotherapy suite, and she also consented to referral for counselling. Kathy's main objective was to avoid anxiety medication if possible, and as a result, she managed to meet this objective. So here are some of our prehab extended outcomes. We found very much a rippling effect. We prehabbed 10 patients in total. Unfortunately, the project was stopped early because of COVID. We found that 30% of our patients were self-reporting deteriorating symptoms early, leading to prompt assessment and management, and therefore admission avoidance to hospital. We had 2 patients who were in hospital for pain management control, but they were really eager to manage their pain at home, therefore reducing their length of stay. 2 patients attended the smoking cessation service after their prehab session, and they both stopped smoking before the radiotherapy started. None of our prehabbed patients called the out-of-hours cancer helpline either during or after treatment. The average is usually 60%, so this is a benefit. 40% of our patients were referred on to psychological therapies, and none of our prehab group required anxiety medication during their treatment, and this is in contrast to 35% for the no prehab group. We also found that prehab helped us as clinicians to prioritize, and we onward referred to physio and occupational therapy before treatment. 6 weeks after treatment, patients gave us feedback on how they felt the prehab session went, and here's some of the lovely qualitative comments from patients. I understood what everyone's role with me would be. My swallowing problem was assessed fast. I've stopped smoking after 40 years. I started my mouth and swallowing exercises straight away. The radiotherapy video showed me what was going to happen. My wife and I stuck the leaflet on the fridge and looked at it. I looked at it when I was experiencing a new side effect. Seeing it was a normal reaction stopped me from panicking and calling the out-of-hours helpline. And finally, I think if I hadn't spoken to the counsellor after the CNS referred me, I would have pulled out of the treatment altogether. So some of our own prehab milestones and clinician reflections, we all were delighted to see the outcomes so quickly. We felt early screening helped expedite management. We built new relationships, not only with each other, but with the psychological support team. We developed our own leadership skills. We had to meet deadlines, have difficult conversations and with one another. We used the model for improvement to guide and measure our change. We all felt challenged by this, but in a good way. And finally, we all felt that the creation of the side effects leaflet and the radiotherapy video made us feel very proud. So where do we go from here? Well, we've been spreading the word about our prehab project throughout the Northern Ireland Cancer Network. We've put in a prehab bid for the Cancer Recovery Plan. We've been helping to contribute to strategy and prehab policy design for the cancer strategy for Northern Ireland over the next 10 years. We are working to integrate prehab into our existing service delivery. We've proved that prehab invests to save and that we add value from our outcomes. We're role models for other surgical prehab pilots for head and neck here at the Western Trust at the moment. And we're looking forward to supporting new prehab projects here at the Northwest Cancer Centre with our colleagues throughout Northern Ireland in due course. Thank you.
Thank you so much, David. Oh my goodness, I wish I had time to talk to each of you all about these amazing presentations, but we have to move on. So I'm going to hand over now to Alison Ferris, who's going to be interviewing 2 speech and language therapists that started their post during COVID. So that's Shannon and Lisa.
That's great, thank you, Ruth. And hopefully you'll be able to see us all. Okay, so I just want to say thank you to Shannon and Lisa for agreeing to do this today. So maybe, am I getting quite a lot of feedback? Everybody else okay? Yeah. Okay, so just maybe if you just want to introduce yourselves very quickly, girls.
Hi, yes, my name is Lisa Kelly. I am working with South Eastern Trust. I qualified in 2020 and I'm now working 4 days a week in a speech and language unit attached to a mainstream and 1 day a week in community.
Yeah, and I'm Shannon. I graduated in the same year as Lisa. I'm also working in South Eastern Trust in the paediatric team, and I'm a split post between an SLD school in Lisburn and a community clinic in Newton Ards. But I did 6 months in the adult team before that as well.
Brilliant, thank you. Lisa, could you tell us a little bit about the interview process during COVID and how you got the post that you're currently working?
Sure, I wasn't actually employed off the Band 5 waiting list. I was employed from the workforce appeal, but I did do the Band 5 interview as well, which was, it was interesting. Doing an online interview was definitely new for me. I had never done that before. I did have some nerves about it, but we were given a link to try before the interview, and we were given a number to call during the interview if there were any technological problems, which thankfully for me there weren't. So that all went quite smoothly. So another positive thing was that you didn't have that stress about car parks and finding your way there and all that. So that was quite good. It was a little strange doing an interview in my living room. I felt I did miss a wee bit of that adrenaline that you need when you get dressed up in your suit and go off to an interview. But overall, it was as positive an experience as an interview can be. So yeah.
Great, thanks Lisa. And Shannon, would you mind telling us just a wee bit about the induction process and sort of getting to know a new team, especially during...
Yeah, so I suppose I had 2 inductions during COVID in the adults and then paediatric teams. So they both involved a corporate induction to the trust, which was via Zoom, but then thankfully I was able to meet with all line managers and supervisors in person, which was great. I think that's probably one of the hard things about coming in during COVID is that it took a while to get a chance to meet the whole team and to get to know people. You kind of were the new person on the Zoom team meetings, flicking between screens to try and put faces to names that you'd heard so much. But it's definitely been made a bit easier with everyone being so welcoming. I think there's also been positives to coming in at this time in that I've had really good access to training since it's been online, and it's been really easy for me to get good access to that, which has been brilliant. And I think finally just having 2 inductions to the trust has allowed me to see something quite positive to come out of COVID in terms of how the service has learned to adapt. So whenever I started my paediatric post, the trust had a Page Tiger induction that was available, and it just gave a really helpful visual overview of kind of who's who within the speech therapy teams in the trust, as well as the really practical information that you needed to know. I think starting any new job can be a bit of a whirlwind at the start and being inducted, so it's really great to be able to go back and access that information at any time.
Brilliant, thanks Shannon. So reflecting on the first year of working as a speech and language therapist, are there maybe experiences or moments that you have you both think that you will sort of never forget or you're going to treasure? Lisa, is there anything you would like to share?
Sorry, I needed to unmute myself there. Sorry about that. So yeah, so I didn't come to speech therapy straight from school, but it's a decision that I have not regretted for a minute. I have loved every second of being a speech therapist, and a big part of that is our team. The community team and the education team have been fabulous. They've really welcomed me. You get a real sense of team. You're never made to feel like your questions are silly. You're even asked your opinion sometimes, which is a bit mind-blowing, but it's great. They've been fabulous. And the biggest privilege for me is just that groundwork with the children. You know, when you see, and this happened very recently for me, for a little one who was really struggling with some of those speech sounds, and then that moment when it just clicked for him and his sense of pride and accomplishment was just beautiful to watch, and it was a real privilege to be there when that happened.
Thanks, Lisa.
Yeah, so I think as I was kind of reflecting on my first year, I feel like I've worked with 3 very different caseloads or client groups already, and I'm really glad for that experience. I mean, the variation within speech therapy is one of the things that drew me to it, and I think that's come across today really clearly. But I think as newly qualified, it could feel a wee bit overwhelming initially. And something that I said a lot at the start of both posts was, I just can't wait to feel like I know exactly what I'm doing. But so often I was met with the response, yeah, me too. And that was with no matter who I was talking to. So I think it's really reassuring, and it's lovely to be in a job where we're constantly learning from each other and sharing ideas and experience and challenging each other as well. I think a standout moment for me is maybe one from early on in my speech therapy working life, when the adult post, when I went out to see a gentleman who had had a stroke previously. And when I met with him and his family, they were able to tell me that his son was getting married later on in the year, and a real goal or a real desire of his was to be able to communicate in some way, just a one line of welcome to the family to his daughter-in-law at the wedding. And it stands out to me, not even because of the outcome, but just because it is a reminder of how special it can be to be trusted by families and to be able to work with them on something that's really significant and important to them personally.
Brilliant. Thanks, Shannon. Thank you, Lisa. I think it's really positive for those of us who've maybe been around a wee while longer, just to hear how refreshing and how you have really settled into your posts. And thank you for everything you've done in the last year. We're now going to hand over to Paula Hassan from the Northern Trust. And Paula is going to talk to us about the work she's been doing with eating, drinking and swallowing in infants. So just pass you over to Paula, hopefully.
Hello, yes. Last but not least. Yes, here I am. So this case study really is to highlight the important work that speech and language therapists do working with children who have eating, drinking and swallowing difficulties. This particular case study relates to a little girl called Ava, who was referred in to our services at 5 months of age, and she had complex congenital heart disease, and she was referred in post-surgery with an ANG tube in place and had real difficulties developing her oral feeding. And by the time she was discharged from speech and language therapy, she was fully orally fed and her ANG tube was removed, which was fantastic. So I'll give you a little bit of a background on Ava then. Ava was referred to our local speech and language therapy services by the speech and language therapist in the Royal in October. As I said, she had congenital heart disease, but she had had her repair in Crumlin Hospital in Dublin. And by the time she came to local services, she was fully NG tube fed, and she had real difficulties establishing any oral feeding at all. Her mother was really, really concerned. She had reflux, she had regular vomiting episodes, she was really slow to gain weight. And on top of that, there were concerns about her safety of her swallow and oral pharyngeal incoordination. So what did we do, or what do we know? In terms of what we know that infants and children who require tube feeds because of complex needs are at a risk of developing oral hypersensitivities due to prolonged tube feeding. And we know also that consequently these children are highly likely to develop significant difficulties in learning to tolerate eating orally. And this may have an impact on the child's social and emotional development. So speech and language therapists work very closely as part of the multidisciplinary team with parents and the other professionals to help support children's eating, drinking and swallowing skills where they can eat and drink and swallow safely. So what did we do? So I linked with the speech and language therapist in the Royal and had a follow-up phone call and a face-to-face assessment and advice appointment with mum, and advised mum on things to do to help support Ava's oral feeding in terms of positive oral experiences, continuing her non-nutritive suckling, taking water sips, engaging in messy play activities to be completed every day, and developing her oral tastes using the spoon in the bottle. And while she did that, we monitored her swallow safety to check that her swallow was safe and her health was good. In terms of the outcome, well, what was the outcome? The outcome was really that Ava's mother was fabulous and fantastic and worked through all the advice given to her and personalised it to suit Ava. She was really consistent implementing all the advice and working with the multidisciplinary team. And in May 2021, Ava's NG tube was removed, hooray. And she was fully orally fed. She took a mixture of bottle feeds morning and night and 3 spoon feeds a day. She was delighted, her mum was delighted, and the well-being of the house in general improved, and her weight had improved, and it is now static, and she's tracking the 9th percentile for her weight. So it was a really great outcome for Ava and her family. What were the factors for success? Well, really, the factors for success were early intervention from speech and language therapy, both within the Royal and then within local services, really good handover between the therapists regionally and local therapy. And really, I can't really emphasize enough Ava's mother and her family and the excellent motivation they had and perseverance and consistency in really implementing all the advice. Alongside that, she'd had her cardiac surgery and her swallow was safe. And the dietitian worked closely with Ava's mum to adjust her tube feeds to create hunger for more oral feeding. And Ava's own readiness and acceptance was really important. In terms of Ava's mother, really, and family, it was actually her motivation that led me to wonder, you know, how do we get this for other children, you know? How can we support this for other families in similar situations by harnessing Ava's parents' lived experience? Because whilst I taught Ava and her family 1 or 2 things, they definitely taught me 1 or 2 things as well. So I asked Ava's mother if she would, what would be her top 5 tips that she would give to other families in similar situations who are struggling to develop their child's oral feeding. And she sent me some lovely emails and talked to me through what her tips would be. And her tips mirrored the original advice given, which was good. So I won't read them all out today because we don't have time, but I will go through the first few tips with you. So in terms of one parent's top 5 tips to another parent, her tip 1 was to do messy play and do it every day. And Ava's mother said, I persisted with the messy play. At the start, it was really difficult as Ava would gag and smell at any of the foods, at the smell of any of the foods. But to me, the key was finding her favorite toy or object and using it. Ava's favorite objects were keys and a remote control. I put a small amount of custard at the side of the keys and the remote and let her hold it. It wasn't long until she was lifting the keys out of whatever food I had them in and chewing the remote control covered in the yogurt. During feeding, we drove cars through gravy, we drove cars through yogurt, we drove cars through curry, as well as hiding dried food within her toys. As she got older, she really enjoyed the play aspect and started to really enjoy it. So Ava's mother's second tip, tip 2, was change the tube feeding times to after the meal times. So Ava's mum said, I always tube fed Ava before I started to make everyone else's tea. So I changed her feeding times to see would she get hungry with the smell of the food cooking. This was a really massive turning point for Ava. With the smell of the food cooking and being involved during the tea time, she would have cried looking for food. It was from then I started giving her proper spoon feeds. It started with a few spoonfuls and just slowly but surely progressed. Ava called the shots and I very much went with her every day. It was so hard, as some days she did so well and others she wouldn't take a thing, but persistence really was the key. Her third tip was involve your child in family meal times. Her 4th tip was don't force it. If your child ever refuses, don't push it. And her 5th tip was let your child lead. So really it was by harnessing really Ava's family's experience that I'm hoping that these tips will help other families for whom the advice is suitable to help their child develop their oral feeding skills where this is suitable for the child. Because you never really understand a person until you consider things from his point of view, until you climb into his skin and you walk around in it. Thank you. And there are my details and my email and my phone number if anybody would like any more information or needs to get in touch with me. Thank you.
Thank you so much, Paula. Wow, what an impact all of these services have. I'm just going to hand over now for our closing comments to Hilary McFaul. Thank you.
Thanks, Ruth. Wow, how do you sum up the last hour and a half of our time? This has been a fabulous webinar, and I just want to say a few things. But before I start, I want to just let you all know that there's a poll going to appear on the screen shortly, and we would really value if you would just take some time as I'm talking just to complete that poll, just so we get your feedback about the webinar. Thanks very much for doing that. So I want to just say a few things about my reflections on what I've heard today. Our overall theme for this webinar was celebrating the impact of speech and language therapists in people's lives, and every single presentation has done that so eloquently. And I want for taking the time to prepare and deliver their presentations to help us understand all of the work that's been happening. Jenny started off by challenging us to continue to work out loud, and that's definitely going to sit with me, and I think all of us can take that away and apply that to all of our work, so that we are continuing to raise the profile of the unique contribution we make to children and adults' lives. Then we heard from Ruth, and it was lovely to have Ruth introduce herself to us. And Ruth, thank you so much for your honesty and for sharing a little bit of your own journey of mental health, and for reminding us to just breathe, and for sharing your tips. That was really helpful, and how important it is for us in the current time to look after our own well-being. Marion then spoke to us about the Tuck Shop project, and I was completely blown away by that, Marion. I just couldn't believe, first of all, how complicated the Tuck Shop menu was in Hydebank. I don't think any of us would have found it easy to order from that, but just how practical your project was, and how multidisciplinary it was as well. And I was just thinking about that young lad who wasn't able to order pickled onion space raiders, and how important it is that we facilitate our clients to be able to be independent and meet their needs. So what an excellent project. Then we heard from Ruth and Mary Alva about speaking to them at home, and just how amazing it is that we are able to support a minority group and to encourage them to understand the benefits of bilingualism for their children's communication skills, and also for them to remain connected with their culture. What a fabulous piece of work. And then Joanne spoke to us about the 5 good communication standards and how that was applied across an ALD service, and the shift from referrals being very dysphagia focused to back to communication, and the importance of communication. And Joanne, you shared with us some excellent outcomes. Really interested in your use of TOMS and the Roots tool. I might be getting in touch with you about that. I hope you're coping with all those increased communication referrals. So I'm sure that has been a challenge in itself, but really excellent to see how this project has improved the confidence and knowledge of the staff in these daycare centres. And then Alex and Erin told us very eloquently about the telehealth audits. Really interested in this very timely audits outcomes around the children's improvement in attendance for telehealth, but also the outcomes from telehealth versus clinic-based, and the challenges that there are to telehealth. So really interesting, and lots of food for thought for us all going forward. And then Amy introduced us to Mr. O, and brought us right up to current challenges with COVID, and how amazing it was to hear about the Nightingale service in White Abbey that was set up from scratch as a multidisciplinary team, and just the huge impact that intensive input from speech and language and the other disciplines has had on Mr. O's life, but also the lives of those other patients that have gone through White Abbey. Really excellent, and very interesting to hear about that. And then David's award-winning project on the impact of speech and language prehab program for cancer patients. Another excellent example of multidisciplinary working. And David, many congratulations on winning the Macmillan Professional Excellence Award for Transformation and Innovation. And lots of opportunities here for scale and spread across the region. And then Shannon and Lisa in an interview with Alison, talking to us about what it's like to start working within a pandemic. And I cannot imagine what it was like to start a new job in the middle of a pandemic, such a challenge. And Shannon, I can't wait to know exactly what I'm doing too. And I think that we are a profession who are committed to continuous learning, and we're all learning together on that. Then Paula spoke to us about Ava and her journey and the work that was done with her parents and with her in relation to her dysphagia. Really great to hear about the really good relationships between regional and local services and the importance of those services working together, and such a powerful account from Ava's mum about the top tips that she would pass on to other families going through similar experiences. And it just reminded me how important it is that we have our parents as partners in therapy, and what that had taught that mum, and how she can then go on and advocate for other families. It's just been a fabulous afternoon, and what a privilege it has been to listen to all of the great work that's been going on. I just want to say on behalf of the 5 regional managers that I would want to extend our sincere thanks to each of you for working through this extremely challenging 20 months. None of us have ever experienced a time like this, and yet all of you have held our services together. You've gone above and beyond in many aspects of your work, not least of all in developing new ways of working. In our trust, we often talk about engaging in transformation as being a bit like redesigning the airplane while it's still flying. I think in the past 20 months, we have all rebuilt the plane possibly a number of times while it's been flying through extreme turbulence. Thank you again to each of you on this webinar, to those of you who will be watching the recorded version, and please pass on our thanks to those who may not have had the opportunity to watch this webinar. Your contributions to your services have been incredible in the face of long and unrelenting pressures. And on behalf of all of the managers, I want to wish you all a restful, peaceful and safe Christmas. And I hope that 2022 will be a better year for all of us. Thank you very much for your time. Thank you to the Hub for organising this, and a particular thanks to Janet, who has been amazing in the background at making all this technology work. And thank you to each of you who have attended and engaged so well with this webinar. Thank you very much, and enjoy the rest of your day.